Hi, I'm Sue Robinson, and I'm here to talk about what's new in pregnancy and immune thrombocytopenia. Firstly, thank you to the ITP Support Association for inviting me to talk about ITP in pregnancy. I'm a haematologist at Guy's and St Thomas's. My clinical practice includes obstetric haematology and looking after women with blood-related diagnoses in pregnancy. There's a natural decline in the platelet count in all pregnancies. Platelet counts of less than 100 are only seen in 1 in 100 pregnant women, however, and platelet counts of less than 80 are only seen in 1 in 1,000 pregnant women in the absence of another cause. Immune thrombocytopenia is one of many causes of low platelet counts in pregnancy, and ITP may be diagnosed prior to pregnancy or can be diagnosed in pregnancy. In women with a prior diagnosis of ITP, it is most likely they will have had a chance to discuss pregnancy plans with their haematologist, and I would strongly encourage this. When diagnosed in pregnancy, women are likely to present following blood tests taken by the general practitioner or midwife at the booking visit, or later in pregnancy, or in the event of any symptoms of bruising or bleeding. Some of the challenges of ITP in pregnancy are bleeding, thromboses, and treatment-related side effects where treatment is required. Where a pre-pregnancy meeting is possible, this should provide an overview of current ITP, medication if required, and provide the woman with details of the team available in pregnancy and proposed management antenatally and postnatally. Prior to pregnancy, any medications contraindicated should be discontinued, and alternative treatment may be needed to commence at this stage. In pregnancy up until 34 to 36 weeks, in the absence of bruising or bleeding or a planned procedure, a platelet count of 20 to 30 is generally considered to be safe. From 34 weeks, the team will aim to maintain a platelet count above 50. When treatment is required in pregnancy, first-line treatments are steroids or immunoglobulin. The frequency of follow-up in a haematology clinic will depend upon individual requirements, symptoms and platelet count, and any treatments required. The haematologist will work closely with the obstetrician, midwives, fetal medicine colleagues if required, and anaesthetists to ensure a multidisciplinary approach. Each clinic will include a review of any symptoms, current platelet count, discussion re any treatment required, and discussion around how pregnancy is progressing and any preparations required. So has COVID impacted the clinic model of care? We've reduced unnecessary face-to-face appointments to make every contact count. Full blood counts are taken when attending the midwife or obstetrician or a scan appointment wherever possible. And there is also an amount of community phlebotomy. Consultations, where possible, are by telephone or video and face-to-face as and when required. So what if first-line treatment doesn't work? Steroids and immunoglobulin may be combined, or second-line treatments may be considered. Azathioprine and other immune suppressive drugs listed that are considered safe in pregnancy may be continued or commenced in pregnancy as necessary under the guidance of a consultant haematologist. Drugs to avoid in pregnancy that may harm the unborn child should be avoided in pregnancy. Where additional immune suppression is required in pregnancy, azathioprine is generally considered safe and well tolerated. The unborn child also lacks the enzyme required to convert azathioprine to its active form. However, the effects of azathioprine to the mother are limited as it takes 6 to 8 weeks to take effect with regards to ITP. Are there any other treatments? Rituximab may be considered in pregnancy in refractory cases. However, this may result in a temporary reduction in the newborn's immunity and potentially increase susceptibility to infection. And as always, there is a risk balance to be considered with regards to treatment options. Thrombopoietin receptor agonists may also be considered in exceptional circumstances, although data regarding tolerability and toxic effects on fetus is limited. Case studies so far show a good response and safety profile, however. With regards to preparation for the delivery from 34 weeks onwards, the treatment goal is to achieve a minimum platelet count of 50 for delivery. And the platelet threshold for epidural in most cases is 70. However, senior anaesthetists may consider an epidural in certain circumstances with a platelet count of more than 50. All women should be risk assessed for thrombosis in pregnancy, antenatally, intrapartum and postpartum, as is standard of care in all pregnancies. There's a small chance that babies born to mothers with ITP will have a low platelet count temporarily. However, major bleeding is uncommon. The baby's platelet count may fall further in the first few days after delivery, and a second baby platelet count may be required. There is no correlation between the severity of maternal ITP and the baby's platelet count, however. ITP should not alter the maternal or women's services team decision around mode of delivery. There is no evidence that caesarean section is safer compared to vaginal delivery. However, fetal monitoring with scalp electrode, blood sampling, ventouse, or rotational forceps should be avoided. A cord blood platelet count is taken at delivery to determine the baby's platelet count. The management approach is summarised in this slide, provided in a publication by Nikki Cooper. Important also is the communication between the teams, and during pregnancy, a treatment plan and a delivery plan will need to be provided to the joint teams looking after these women. An interesting development in the maternal medicine networks is the development of maternal medicine centre networking, and it's important to consider what this might mean for ITP. So in October 2021, the service specification for the provision of maternal medicine networks was published by NHSE. This provided pre-pregnancy, antenatal and postnatal care for women who have significant medical problems that predate or arise in pregnancy or the postpartum period. The document sets out a guide to establish a service that is tailored to local expertise, needs and opportunities. Maternal morbidity and mortality may be increased by diseases that predate pregnancy and by complications that arise during pregnancy. Pregnancy induces significant changes in all aspects of physiology, and so treatment optimal outcomes are achieved where care for pregnant women is guided by consultants with specific pregnancy expertise, with input from the relevant physicians rather than the other way around. As many of these conditions are uncommon, advice and for some women care should be provided in a small number of designated specialist centres to concentrate expertise and improve outcomes. So what does this mean for ITP? Because we can see there are three categories. There's category A, where care is expected to be provided locally. Category B, more of a joint network approach where there may be virtual advice or a joint pregnancy plan with the local maternity unit, and category C, where highly complex cases, diagnoses in pregnancy will be led by the maternal medicine centres during pregnancy, and this includes a plan for delivery. So with regards to ITP, For women with immune thrombocytopenia and platelet counts greater than 75, the planning is for these services to be provided locally to women within local areas of expertise. Category B, this document suggests where the platelet count is less than 75, there should be engagement and advice and guidance provided through the maternal network with the maternal medical centres. And these are a list of other haematological conditions which require category C care. So I think we will see this evolving over the course of 2022 as the maternal medicine centres look across their different disease groups, from cardiac to respiratory medicine to haematology. And I think this is something we should expect to hear more about, and how women want their care provided who have a diagnosis of ITP is really important with regards to this, and something that I think would be really good to have a discussion about with the ITP Support Association. So I'd like to thank everyone who has provided input into my talk today, and I look forward to working with you all in the future. Thank you.